Assalamu alaikum. First of all, I want to thank my professor and my colleague, especially Dr. Nuran Hussein, for this invitation to attend this first international radiological meeting. My topic today will be about ultrasound-guided breast procedures. I don't know. Okay. The objective of my presentation is that image-guided biopsy in comparison to surgical biopsy, reviews the indication and contraindication of breast biopsy, reviews the type, preparation, equipment and technique of the breast biopsy, identify the complication of breast biopsy and the importance of radiopathological correlation. Everyone knows that improved screening and diagnostic technique increase the incidence and the prevalence of the breast cancer worldwide. So percutaneous imaging-guided needle biopsy is essential and recommended in management of suspicious breast lesion, even if the lesion appear benign on imaging. Percutaneous biopsy replaces excision biopsy, and this is fact. Why? Because less cost, less complication, no scar, and almost same sensitivity and specificity. The indication of breast biopsy, any patient reported as BIRAS 4 or 5, of course, she will take a biopsy. And also, in certain circumstances like, of patient with BIRAS 3, we ask for biopsy. If there is genetic or family risk, if there is medical or social difficulty in follow-up, like the patient is maybe become a pregnant or it is difficult to follow up, so we advise the patient to take a biopsy. Contraindication to take a breast biopsy, almost no absolute contraindication, but there is a relative contraindication like overlying skin infection, high risk of bleeding, and this be controlled by INR, and morbid obesity in case they need to take a biopsy by stereotactic biopsy because chair table have weight limits. Types of guided biopsy. Different percutaneous image-guided techniques are available to diagnose palpable and non-palpable lesions with maximum degree of accuracy and full information about tumor, about its type, grade, invasion, hormonal receptors, and you know this is very important nowadays in the management of cancer breast. We have fine needle aspiration cytology, true cut needle biopsy, vacuum assisted breast biopsy, and breast lesion excision system plus. About fine needle aspiration, it is just a smear cytology analysis. It is easy, safe, fast, and low cost. But it has a disadvantage. It is high rate of false negative result compared to core needle biopsy. And also, it couldn't distinguish between benign and high risk BIRAS 3 lesion and DCIS. Could not give information about tumor biomarker status required when new adjuvant chemotherapy is needed. So we will not use fine needle aspiration biopsy, no. There is some indication, very important in fine needle biopsy, like diagnostic for axillary nodes, especially intermittent lymph nodes, type 3 and 4. And here I want to just give you something. If you find patient with axillary lymph node pathological and there is no lesion in the breast, please don't go for fine needle, please go for true cut. This is very important. Why? Because true cut biopsy can differentiate if it is lymph node from lymphoma or a lymph node due to metastasis, and we can do also the hormonal hormones on it to can know where is the site of the metastasis. And also in lesion adjacent to the sensitive structure as breast implant or deep-seated lesion along pectoralis muscle, it is preferred to go for fine needle aspiration. Also, fine needle aspiration has a therapeutic rule like drainage of complicated cysts, seroma, hematomas, and in lactation and non-lactation breast abscess drainage. We use in fine needle aspiration, needle used for intramuscular injection. Multiple cells are collected by to and fro motion and smeared on glass slides fixed with alcohol. And this is very important, and immediately we had to fix our cells. I think I have to go back. There is here short video to see how is the needle go in and out. Okay. And this is again to see how your samples are taken and on the slice. First of all, your slice has to be marked well about the site of the lesion and the name of the patient. You will have the slice go horizontally in this direction, then from up to down, and slowly you try to spread the cells all over the slice gently. Please don't crush the cell so it is easy for the pathologist to give you accurate result. Now, core needle biopsy. Percutaneous image-guided core needle biopsy has become a frequently used method to diagnose breast lesions. Sensitivity is very high, especially if you use 14-gauge needle. In 2% of the cases, core needle biopsy may provide false negative diagnosis. And this is for what? For error in lesions targeting. What's the meaning of this? Sometimes when you are trying to take a biopsy from the lesion by the true cut, bleeding occurs, and this obscures the field and you couldn't see the lesion well. And also sometimes the lesion is very mobile and it is very, very difficult to take a good tissue from it. And again, when the lesion is benign and malignant, mixed heterogeneity, the sample only contains benign tissue. That's why, that's we can see also in DCIS and lobular invasive cancer. That's why recommendation come by NCCN that any case diagnosed as typical ductal hyperplasia, it has to be undergo surgical biopsy to rule out DCIS or invasive carcinoma. And also, more tissue may be needed in case of lobular cell in cytocarcinoma, mucinous producing lesions, or potential phylloides tumor and papillary lesions. So if the pathologist gives you a report with any of these items, maybe he will ask you again to take for him more tissue so the pathologist can be sure about his diagnosis. This is some example for the needle in the market. And here I can see how is the true cut biopsy we are taking. You can see now the needle going inside the lesion, and the notch start to cut and take the sample out. Now we will speak about the third type, the vacuum-assisted breast biopsy. It's developed at the end of 1990. Used vacuum device increase the volume of the tissue, leading to more accuracy than core needle biopsy, and lowest false negative rate in biopsies. Use of larger diameter device will yield, of course, a large volume of tissue. And also vacuum-assisted breast biopsy also allow complete removal of the lesion. And this is the device of the vacuum. You can see the needle, and this is the hand. There is two buttons here, one for sampling, one for vacuum. And this vacuum, we can use it when hematoma is there. We can aspirate this hematoma easily, and this is connected to basket to collect the sample. This is the mechanism how the vacuum is working. If you remember that the how is true cut is working, it just you put the needle inside the lesion and start to target it when it is in the middle. But here it is different. You can see the needle is below the lesion, and then there is a vacuum process make the lesion go inside the notch, cutting, then remove the lesion into the basket. The indication for vacuum-assisted breast biopsy, who will decide I will take the lesion by true cut biopsy or with vacuum-assisted breast biopsy? This depends on the lesion. I will not start to take by vacuum except if I have pathological microcalcification, and I think this is the most important indication to take the biopsy by vacuum. When we couldn't see the microcalcification well in ultrasound, it is better to be taken, not better, it has to be taken under mammo and by vacuum to have a big core so the diagnosis is be sure. Also, sometimes there is inadequate fine needle or true cut result. In that case, the pathologist will ask you to have more tissue, and we can use vacuum also. Sometimes with BIRAD 3 or 4, when the lesion is very small, true cut will not give accurate diagnosis, and in the same, it is better also to use vacuum-assisted biopsy. In papilloma, invasive carcinoma, and also it has a very big rule sometimes if you want to remove the lesion as a therapeutic. This case, you can see segmental distribution of microcalcification. The breast is small, and she preferred to go first for biopsy by vacuum-assisted breast biopsy, and this was the result. This specimen from the core, we take a specimen mammogram, and I think you can appreciate there is a microcalcification seen within this core, and the result come as fibrocystic with sclerosis, adenosis, and this patient is not going for OR. She is under follow-up, and she is fine. Regarding the therapeutic use of vacuum, benign lesion up to 3 centimeters are completely removed with minimal or no scarring. Extra sample should be obtained in different direction, and this is very important to be sure that the lesion is completely removed. Complete removal of the imaged lesion was excellent if you use gauge 8. Ultrasound follow-up examination were performed on the following day and 3 to 6 months later to assess residual tissue and scarring. FDA approved use of vacuum-assisted breast biopsy for therapeutic purpose of benign lesion. And this is an example again for fibroadenoma in young lady, and this is after we excised by vacuum, and clip has to be inserted in the site of the lesion. This is again very short video. Here you can notice that the needle is not like in true cut, not in the center of the lesion. It is coming below the lesion, and this is the cutting mechanism, and then suction of your sample into the basket. This is how the cores appear. You can appreciate how it is larger than the cores by true cut, and this is the whole lesion after we remove it. You can see also how this is mixed between the lesion and the fat, because we had to take more samples after you remove the patient to be sure that all the lesion had been excised. Breast lesion excision system plus. In the last decade, percutaneous image-guided system developed to completely remove small breast lesion using radiofrequency as a whole mass, high accurate tissue diagnosis, and offer option for percutaneous lesion removal. But again, this lesion had to be small, not more than 2 centimeters, and still this under research. This is the plus needle with the basket that engulf all the lesion, not cutting, and take it out for the biopsy. Again, it is still under research. Choosing among ultrasound, mammography, and tomosynthesis and MRI, which modality I will use for my biopsy depend on the visibility of the lesion to be target. How you can see the lesion better is the way you will take the biopsy. And of course, the site of the lesion, the experience, and the availability of the modality. Ultrasound is the best choice if the lesion seen, because it is comfort for the patient and comfort for the radiologist also. Available, no ionizing radiation, easy, safe, effective, fast, and of course it is cheap. And there is very important thing that full control of the needle position in real time. Neither stereotactic or MRI guidance offers this advantage. And you can take multiple lesions, unilateral or bilateral, safely done in one session. Also, biopsy, you can do it by either any type, fine needle or core needle biopsy or vacuum, any type you can use it with ultrasound. The only disadvantage of the ultrasound is when the lesion is not seen by ultrasound or with microcalcification, especially with no definite lesion. Preparation. This preparation you can follow for any patient going for biopsy. At the day, before the day of procedure, you had to discontinue of the anticoagulant drug the patient is taking, of course, after communication with the patient's physician. Review the previous breast imaging. All of them had to be reviewed to decide your site of the lesion, your size of the lesion, and everything about the lesion. Choose the optimal modality. The radiologist, he is the one who will choose the optimal modality. Either ultrasound, mammography, tomo, or MRI, according again for the visibility and his own experience. Explain the procedure and take for the patient, and it is very important.
Thank you, Dr. Amal, very much for the very nice scientific presentation in ultrasound guided procedures. And now we follow for the third lecture by Dr. Naveen Faris. Dr. Naveen is